Everyone to Health for the World International Grand Rounds. It's my honor today to introduce our Grand Round speaker, Dr. Joshua Nickerson. Dr. Joshua Nickerson is a renowned neuroradiologist and educator around the world. Dr. Joshua Nickerson is a neuroradiologist and professor of radiology in the Oregon Health State University in the Department of Diagnostic Radiology. He also serves as an associate program director for the Diagnostic Radiology Residency Program. Prior to joining the faculty at OHSU in 2018, Dr. Nickerson was vice chair for education and residency program director at the University of Vermont Medical Center, where he also served as division chief for neuroradiology. He's a passionate educator who's active in the Association of Program Directors in Radiology, as well as on committees within the American Board of Radiology and the American Society of Neuroradiology. Dr. Nickerson is a researcher who has published manuscripts both within neuroradiology literature on topics such as susceptibility-weighted imaging, functional MRI, and intracranial infection, as well as within medical educational journals relating to faculty development and quality assurance in residency education. Dr. Nickerson is a well-traveled educator who has presented both neuroradiology and resident education lectures around the world, including in Scotland, Sweden, Netherlands, Saudi Arabia, and recently also in Kenya as ASNR and Osborne International Outreach Visiting Professor. He's also invited to speak in numerous regional, national, and international meetings around the world. He's a passionate and a very well-renowned neuroradiologist globally. A native of Montana, Dr. Nickerson has one son. He enjoys beautiful pottery. We were just talking about it. Really, really beautiful work and creative work. Classic cars, pinball, computer gaming, tennis, travel, and fine barbecue. It's my honor to introduce Dr. Nickerson today, and Dr. Nickerson will be talking about toxic and metabolic brain disease.
Thank you very much. Well, it's really a pleasure to be with you all here today. I was going to say this morning, but I know we're in all kinds of different time zones. It's about 7 a.m. here in Portland. I know we have some folks in Africa where I think it's mid-afternoon. And again, thank you very much to Dr. Rahani for the invitation to present. This is really an amazing program that she and others have put together. And the ability for me to be in my office at home in Portland and be able to speak with you around the world is really, this has sort of revolutionized education and certainly medical education in the last several years. So it's really a pleasure to be able to participate. Today, I am going to talk about toxic and metabolic brain diseases. And like I say, I live in, like Dr. Rahani said, I live in Oregon. Behind me in the picture here, this is Mount Hood. This is sort of the view from the hospital at OHSU. If you ever get a chance to come to the United States and visit Portland, it's an amazing location in the Pacific Northwest. It's known for all sort of outdoor activities, and sort of the city sits just down below Mount Hood, which is a volcanic mountain in the Northwest. So this is sort of your peak of Portland behind me. I am, as was mentioned, one of the things that I also do, aside from neuroradiology, is sort of educational theory in medicine and radiology. And I am a firm believer in the data that suggests that most folks don't have a great attention span beyond around 10 to 15 minutes. And I know I would certainly put myself in that category as well. And so one of the things I really do like to do when I'm giving lectures is try to get folks to participate a little bit. So if you happen to have your phone handy, or you can, from a laptop, although I think phones work better, if you want to go to this site, I apologize. I have not changed my address on Poll Everywhere since leaving UVM years ago, because it's actually extremely difficult to change your address from Poll Everywhere. But if you go to pollev.com/UVM Neuro, I do have a few audience response questions sprinkled into this talk to try to sort of keep you engaged. I am also going to present these basically as a case series. So we're going to go through a lot of different topics, but we'll get to those in just a second. So first of all, just to test out whether or not people are able to log in, if you are able to go to this website, I'm curious. I know that there are lots of folks in individual classrooms that are logged in sort of as one login. But if you are inclined and want to type in where you're joining the presentation from this morning, this is one of those sort of audience response toys. This is called a word cloud. It'll show us where folks are logging in from. I see one person has logged in. Maybe I'll give it one more second. Oops, we'll go back and see if a few other people want to answer the question. But I won't spend a bunch of time on this. Again, if you have a phone, there's a couple. If you have a phone or a laptop or whatever you're viewing the presentation from, just pull it out and answer the question. So again, I won't spend a whole lot of time on this. Let's see where people are from. Hungary, excellent. And the Bronx, very nice. Well, I know there are some other folks, but well, as you get a chance, if you have a chance to pull out Nigeria, excellent. Yep, I knew there was one from Nigeria coming. Zambia, excellent, very nice. All right, very good. So let's move on. Oh, Ghana, good. I kind of want to stop. I want to see these answers, but I know you all want to get to the cases and see what we're going to talk about. So these are not the order we're going to go in, but I have sort of divided the topics into two different areas, sort of, oops, my silly Zoom window is giving me a hassle here. Toxic brain injuries and metabolic brain injuries. And so we're going to go through some external exposures, things like drug exposures. We're going to talk a little bit about alcohol-related disease that we see in the brain. And then we're going to go into the very intimidating world of metabolic brain diseases. And I think there are a few things that make trainees get nervous more than talking about things like leukodystrophies. But I hope I will at least show you a few cases to try to make it easy to differentiate the more common patterns. And for those of you who are studying for exams, I heard Dr. Radicki is looking to take a few of our exams here soon. Maybe I'll give you a few pearls for what kind of questions people like to ask about these topics, because even though you may not ever see a whole lot of leukodystrophies in real life, you may see them on tests. They tend to show up more frequently there than they do in reality. All right, so let's talk about this first case. So as I show you these unknown cases, a lot of times when I'm teaching my residents, I actually will have them sort of describe the findings. But I'm going to describe the findings for you. But I want you to start thinking about, as I'm going through those things, what would your differential be? What would you say about this if this comes across your desk on any given day when you're reading cases? So this is a young patient, about 20 years old, and he actually was a participant in a research study, and I'll tell you more about that in a few minutes. And he came in and got this scan. And you can see that on the left, there are 3 flare images, and on the right, there are 3 diffusion-weighted images. I'm not giving you the ADC maps in this case because I didn't want to make the screen too crowded. But I promise you that those areas that are bright on the diffusion-weighted imaging were also dark on ADC. And you can see that he's got this sort of diffuse and fairly symmetric abnormality, which is involving the corpus callosum. It's hyperintense. It actually looks a little bit expansile in the region of the splenium, but also sort of anterior body of the corpus callosum, quite hyperintense on diffusion-weighted imaging. The rest of his brain looks quite normal. You could maybe argue, or his vent's a little generous for 20, maybe. We'll get to that in a second as well. So what would you say about this? He's asymptomatic, in fact. I'll tell you that he was on the scanner, and it was actually part of, like I said, a research study. And I happened to be the person in charge of sort of clinical overreads of these research studies. So I got a call from the technologist, said, you need to come up here and look at this MR in this kid. And I said, all right, whatever. So I walk up there and I take a look, and he comes out of the room, and I ask him, how you feeling okay? Yeah, feeling fine. And I called the PI, the investigator, primary investigator in the study, and I said, is there anything I should know about this person? Like, does he have any medical history? And he said, boy, I don't think so. Let me talk to him. Let me talk to his parents. So the real story turns out that, does anybody know what this is? If you have a guess, put it into the chat. I won't spend a lot of time on that. But so it turns out that he was a member of a college hockey team at UVM where I was playing, and he had just returned the day before from a week-long trip to Jamaica. And upon prodding, it turns out that he had been essentially completely drunk every day, all week. And so it turns out that this is something called type 2. Oh, I already gave you the answer for this. So this turns out to be alcohol. This is Markia fava bignami, type 2 disease. So we think of this Markia-Faba-Bignami disease as in the setting of chronic alcohol use, where you see volume loss, sometimes areas of focal encephalomalacia in the corpus callosum. But actually, there is also an acute form, and that's what this patient had. And so we, advised him not to drink, and he kind of got locked in his house for a couple of weeks for his parents so that he wouldn't drink. And we rescanned him a couple of weeks later, and this was completely gone. So this is a reversible pattern. It may not be. So if it's bad enough, the patients may develop some focal areas of encephalomalacia in the corpus callosum. You should differentiate this from a Clock's lesion. So this is a term that was actually coined by a colleague of mine at OHSU, the cytotoxic lesion of the corpus callosum, which will also be quite bright on diffusion-weighted imaging and will also be bright on FLAIR. It tends to be quite limited to the splenium. So you can see in this case, we have involvement of the body and genu of the corpus callosum as well, whereas Clock's lesions tend to be really just limited to the posterior aspect of the corpus callosum. And those are exceedingly nonspecific. It seems like every time you open a journal article, there's a new etiology for a Clock's lesion. They were initially described in the setting of withdrawal of seizure medications. They were seen in hypoglycemia, other etiologies. Now we're sort of finding them in all sorts of metabolic derangements. One thing you'll notice about this case and most of the cases I'm going to show you today are that the findings tend to be relatively symmetric. And so just as an overarching theory, when you see a symmetric finding on neuroimaging, start thinking about the topic of today's lecture, right? Start thinking about toxic and metabolic disorders. That's probably, if there's one thing to take away, if you're not sure of what something is, you should always try to start putting it into broad categories. And remember that toxic and metabolic tend to often be relatively symmetric. Okay, let's go on to our next case. So this is another young patient and with another very symmetric finding, right? So this was a 35-year-old woman, and she was brought into the hospital by the police because she was found wandering around downtown in the town I was living in at the time, didn't know her name, didn't know how she'd gotten there, who she was, any of that kind of information. And we brought her in and, did the MRI. And here you can see the findings. So again, we have the diffusion-weighted image on the far left. I did give you the ADC map this time to make you believe that this is in fact truly restricted diffusion. So you will note that the medial temporal lobes, and in particular the hippocampi bilaterally, are quite hyperintense on diffusion, and not a subtle finding on FLAIR either, right? Both are somewhat enlarged, hyperintense on the FLAIR imaging in a very, very symmetric pattern. So again, when you see this, you should start thinking about, is this something, a systemic process, a toxic or metabolic etiology? Now, that history that I gave is the typical history of an entity called transient global amnesia. And some of you may be thinking this is a great history for transient global amnesia, but this isn't quite the typical imaging pattern, right? So there have been many cases reported in the literature of findings in MRI in patients with idiopathic transient global amnesia as more of a punctate focus of restricted diffusion in the hippocampus, oftentimes bilateral, but not necessarily. This is significantly more extensive than that. And so this is a less well-described, but having been reported entity called opioid-induced amnestic syndrome. So this patient, when they did the urine drug screen, it was positive for fentanyl. And fentanyl has been the drug that has been most associated with this entity, although it can also be other opioids. But typically, the patients are going to have a positive drug history. I have never seen transient global amnesia in the absence of a positive drug screen give this extensive a disease. So if you see just that punctate focus in the hippocampus, then you should be thinking, could this be transient global amnesia? If you see this sort of extensive and typically bilateral and diffuse involvement of the hippocampus, you should be suggesting that the patient should get a urine drug screen. And most likely what you're going to find is a positive screen for opioids. All right, let's look at another case. Are you seeing a pattern here? The symmetry, right? So here is a FLAIR at a T1, no diffusion this time. History is a little different this time. Again, a young patient, 20 years old, woman, And she came in with tremors. She also, as we looked a little bit deeper into the medical history, found that she had some psychiatric issues as well, some hallucinations in the past. But this is something that was not acute. This was something that had been going on for some time, for some years, in fact. And we see that on the FLAIR image, there is involvement primarily of the lentiform nucleus. So you can see that there's FLAIR hyperintensity involving the putamen, not as much in the globus pallidus. It doesn't seem to be involving the thalami at all. And on the T1 weighted imaging, it's essentially normal, right? So I think you could quibble about, is there maybe a touch of hyperintensity, but I would argue that if you didn't have the FLAIR, you would probably call this T1 imaging normal. So let's do an audience response question. This patient has a copper deposition disorder. And there's your MRI question for the day. So if you have a device handy and you want to answer your question, it should pop up on your screen now. I feel like in every one of my lectures, especially for my residents at home, I try to work in at least one physics question. This is a tough one, I must admit. Is copper ferromagnetic, paramagnetic, or diamagnetic? For those of you who end up taking radiology exams, we do like to include some questions about the physics of MRI, and this is certainly a fair game type of question for that. A couple of responses in. So the answer, that's the kind of response I love to see, actually. We've got one vote for everything. In fact, copper is diamagnetic. So it's going to be difficult on MRI to differentiate paramagnetic from diamagnetic, but what you can differentiate is ferromagnetic. And from a physics perspective, this is all about how many unpaired electrons are in the outer, boy, this is getting deep into chemistry and physics, and I apologize for that, but how many unpaired electrons are in the outer valence shell of the ion. And what you want to know is really, what do these substances do in the setting of a magnetic field? So ferromagnetic things are basically things like iron, and they're the ones that are going to have dramatically strong reactions with the magnetic field because they have a large number of unpaired electrons. And so what you're going to see is large amounts of artifact, and usually susceptibility artifact. So if I go back to the imaging here, you will note that on the T2 weighted image, where we typically would expect to see susceptibility artifact were something to be ferromagnetic, we really don't see anything with significant susceptibility artifact. In fact, the abnormality here is one of hyperintensity. Diamagnetic and paramagnetic have to do with whether or not the interaction with a magnet is positive or negative. So it turns out that things that are paramagnetic are weakly attracted to the magnet, whereas things that are diamagnetic are weakly repulsed by the magnet. So that has some differences. But as far as what we would see on imaging, it's a little bit difficult to tell. So it was a little bit of trivia. But what you should know is that copper is not an element that's going to interact strongly with the magnetic field. It's not going to result in susceptibility artifact. So this is Wilson's disease. This finding is not pathognomonic for Wilson's disease, although I will say that when I have seen cases of Wilson's, this has been the most frequent pattern I've seen, is this very symmetric involvement of the basal ganglia. These patients have abnormal ceruloplasmin, and so they develop depositions of copper throughout the body, including in the eyes. So I think the thing that shows up oftentimes on the USMLE exams are these Kaiser-Fleischer rings, which are these depositions of copper at the periphery of the iris, and they give the iris this sort of brown ring at the periphery. It's very striking when you see it. These patients tend to have tremor, Parkinsonism symptoms, and they often will have sort of early onset of psychiatric symptoms as well. If you do see T1 shortening in the basal ganglia, don't be fooled into saying that's the copper. It is in fact not. So what you're going to see in patients who have long-standing Wilson's disease is they often will develop liver dysfunction as a result of copper deposition in the liver. And that T1 shortening in the basal ganglia is more a sign of liver dysfunction rather than of direct copper deposition. So I think we beat this horse to death. Copper does not cause susceptibility artifact. Again, if I were to see this pattern come across my desk, would I be definitive that this is Wilson's? No. I would probably say that the bilateral symmetric appearance suggests a toxic or metabolic etiology. Wilson's disease could certainly have this appearance, but other deposition disorders and frankly, other toxic exposures could appear similar. Things like in an acute setting of viral encephalitis could have this appearance potentially. But the history is going to help you, right? So if this patient has years worth of symptoms, then you're going to lean more towards a metabolic etiology rather than something toxic or infectious. All right, let's look at another case, another relatively young patient, again with extensive and symmetric signal abnormality. So this patient has had progressive weakness going on for the last decade or so. So this is certainly not an acute process. A T2 and a flare image here. And on the flare image to the right, you see that he has really extensive involvement of the subcortical white matter with areas of T2 hyperintensity in the subinsular regions, frontal regions, periventricular regions. Extremely nonspecific, right? If I were to give you this scan and the patient had more volume loss and they happened to be 75 or 80, you would probably just say extensive nonspecific chronic white matter changes, hypertension, hypercholesterolemia, all the typical things that give you this pattern. But there are a few things here that are different, right? So one thing is that this is not a 75 or 80-year-old patient, right? This is a young person. The other thing is that you have relatively prominent involvement of the temporal lobes. So the next time you're looking at a patient who has white matter disease from those more typical things, whether it be smoking or high cholesterol or uncontrolled hypertension, you will notice that they tend to not have particularly significant involvement of the temporal lobes. I won't say there won't be any, but it's not particularly prominent. And likewise, that is also often true of demyelinating disease. So again, you may have a few demyelinating lesions, but patients with MS or ADEM or NMO, other demyelinating entities, they tend to not involve the temporal lobes to the degree that they involve the other portions of the parenchyma. This patient does have relatively prominent temporal lobe involvement, and that should raise red flags for one other entity. And that entity turns out to be CADASIL. So CADASIL is not common. This is what it stands for. I'm not going to read it to you. I will tell you that at my oral boards, which ages me, obviously, it was a long time ago that I took the board exams. I was asked by my board examiner, what does CADASIL stand for? So if you're one of those folks who asks, do they ever ask you esoteric trivia at the boards? They try not to anymore, but they certainly used to, because that was a question I was asked. And this is genetic. It is found as a result of the Notch3 gene mutation. And you can actually diagnose that mutation via skin biopsy, and that's how they will definitively diagnose this. These patients tend to just have multiple repetitive infarcts involving the white matter, and this temporal lobe involvement tends to be present. I have seen one case of biopsy-proven CADASIL where there really wasn't temporal lobe involvement, and I think in that setting, you're kind of you're not likely to make the diagnosis. But what I tell my trainees is that if you see a patient that has white matter disease way out of proportion to their age, that's when I will include this, at least in my differential. I will still include the other things, such as demyelinating disease, such as small vessel disease. But I think that in a young patient, I will often say, given age, CADASIL is also a consideration. And these patients will have clean vessels too. So it's worth noting that if you do an MRA or CTA of the neck, they tend to have basically clean carotids. This has nothing to do with large vessel atherosclerotic disease. These are small vessels involved with this entity. Okay, let's go on. So another symmetric young patient. Again, if you're noticing a theme here, that's intentional. 17-year-old, so a boy here with Parkinsonism, again, for a few years. And here we're seeing something a little different. So we have involvement, again, of the basal ganglia, but in this case, rather than primarily involving the putamen, we have involvement of the globus pallidus. And on the T2 image to your left, you see that centrally there's actually what looks like cystic encephalomalacia. On the T1 image, we see just, again, cystic change there. And I would say that, for a 17-year-old, this is a subtle finding, but it helps that I know what the final diagnosis was. You notice that the rest of the globus pallidus is actually rather dark. So certainly as we age, we get mineral deposition within multiple areas of the brain, particularly the basal ganglia in the globus pallidus, dentate nuclei, etc., red nucleus. But this is a young patient, and that's kind of a dark-looking basal ganglia. So in the setting of central cystic encephalomalacia, young patient with Parkinsonism, and that darker signal on T2, as opposed to the patient we had with Wilson's disease, this is a ferromagnetic substance, and this turns out to be iron deposition. So this sign has been described as the eye of the tiger sign. I have to say I don't see it very. I'm not sure that looks like an eye of a tiger to me. I haven't seen a ton of tigers, but the ones I've seen don't have eyes that look like that. But in any case, when you see this pattern of susceptibility artifact in the globus pallidus bilaterally with central clearing, and it needs to be a young patient. These patients are going to present as children. So typically they're going to start presenting, 10, 12, teen years. This is not a diagnosis I would suggest in a 75 or 80-year-old, or frankly, even a 35 or 40-year-old. These patients are going to present as children, and they're going to have early iron deposition in those other areas as well. So substantial nigra, red nucleus, maybe even dentate nucleus. And if you did do susceptibility weighted imaging in this patient, because this is a ferromagnetic substance, you would see really marked blooming of the susceptibility artifact in the globus pallidus bilaterally. And that tells you that you are dealing with a ferromagnetic substance in this case. So this is not a common disease, pantothenate kinase associated neurodegeneration. This is the preferred term at this point. It used to go by an eponym, but you really should sort of try to adapt this nomenclature. All right, let's go from the chronic to the acute and the elderly. Well, relatively elderly, getting less elderly every day as I get older. So 65-year-old man in this case, inpatient this time, obtunded, unresponsive, basically. And we have a T2, a flare, a DWI, and an associated ADC in this patient. Again, the problem is symmetric. It's midline in this case. On the T2, you see this sort of ill-defined, almost striated appearance horizontally of the pons, with a corresponding flare hyperintensity involving the anterior and central aspect of the pons, with really marked hyperintensity on the diffusion-weighted imaging. On the ADC, you see that at the periphery, we have hypointensity. So certainly there is some true restricted diffusion, whereas centrally, there may be a little bit of T2 shine through involved with this. And, really you'd want to know how long has this patient had this problem if you wanted to sort out, why are we seeing mixed age or mixed signal on the ADC map. This is a little bit more run-of-the-mill entity as far as something you probably have heard of at this point. This is going to be a typical case of osmotic demyelination. So these patients, at least on exams, are patients who've undergone rapid correction of hyponatremia, and as a result, they can get this demyelination. It used to be termed central pontine myelinolysis, and that may be how some of you have come across this entity. That term has been replaced by osmotic demyelination, predominantly because it doesn't always just involve the pons, right? So you can see involvement of the other central structures, the thalami, medial temporal lobes, basal ganglia, and so really you should go with osmotic demyelination, because if you have involvement of other areas, it can't just be central pontine. In the acute phase, this will enhance potentially. It will be restricting of diffusion. Those will resolve. The diffusion restriction may resolve over the course of the first week, just like an infarct. These patients have fairly poor prognosis. This is very important real estate, as you know. And so the 6-month survival, at least according to the literature, is sub 10%. I do see folks occasionally, when we're reading a scan on an older patient who's got extensive white matter disease and they have that patchy, extensive involvement of the central pons. I read reports occasionally that say this may also reflect sequelae of previous osmotic demyelination. I don't ever say that in a report, simply because of the statistics, right? Like the survival and outcomes for these patients who have this as the cause of their pontine abnormality is so poor that the likelihood that when you see a patient who's got a bunch of other white matter disease and they also happen to have involvement of the pons, that those are the results of old osmotic demyelination are extremely unlikely. So if somebody pushed you and said, is it possible? Yes, statistically it's possible, but it's highly unlikely. It's much more likely to be the result of longstanding hypertension or hypercholesterolemia typically. It can spare the corticospinal tract, as I say here, so sometimes you'll get that sort of like owl eye appearance. So here's another case of a different patient who had this entity, and you can see that those central corticospinal tracts are sort of spared by that T2 hyperintensity surrounding them throughout the remainder of the central pons. All right, let's move on to case 6. So here we have yet another symmetric problem, but again, the history is very different here, right? Elderly patient found down. And there's a CT here. There are not a lot of CTs in this talk, but here's one. And you see that on the CT, they're an older patient, but they have this very symmetric hypodensity in the globus pallidus bilaterally. And on the MR, there is a corresponding flare hyperintensity in the region. But there's other areas of signal abnormality on MR. We see involvement of medial temporal lobes. We see involvement of bilateral cerebellar hemispheres. On diffusion, there are small foci of restricted diffusion at the periphery of the occipital lobes bilaterally, as well as involving the basal ganglia and medial temporal lobes, like we mentioned before. So in the acute setting, what would you be thinking about this patient? Well, oftentimes, if I just give those first 2 images, the CT and the flare, people say, oh, this is carbon monoxide poisoning. And in fact, it is carbon monoxide poisoning. But then when I show the rest of the imaging, people tend to get confused and say, well, I thought carbon monoxide was pathognomonic for only involving the basal ganglia. So one thing I want to sort of stress in this talk is that that is not necessarily pathognomonic for carbon monoxide poisoning. Carbon monoxide poisoning happens because carbon monoxide competes with oxygen for binding on hemoglobin. And so if you are exposed to carbon monoxide, what you essentially are going to see is a pattern of a global anoxic injury. And so this study is really not specific in any way. It's just showing that this patient has had a global anoxic hit. And so this patient could have also had a massive heart attack and had, severe hypotension, or they could have had a drug overdose from some other cause and had hypoventilation. The point is that that pattern of symmetric areas of restricted diffusion just implies that the patient has had a global anoxic injury. So that's a take-home point. I see people often say, this has to be carbon monoxide. That's definitely not true. You can see this in any other number of injuries. But it's certainly something that should be tested for. Let's move on to our next case. Another young patient happens to be pregnant in this case and has a very bad headache. And so we're always a little bit of a struggle with what to do with these folks as far as imaging. We don't like to do CTs in pregnant folks if we can avoid it. We certainly don't like to give gadolinium at all in pregnancy unless it's a life or death scenario because gadolinium is not approved in pregnancy. So working up headaches is a little bit of a challenge. We start with a non-contrast MRI. And in this patient, we can see that she has bilateral symmetric flare hyperintensities. Looks like predominantly involving the subcortical white matter. And it looks like it's predominantly in the posterior brain. So these should start ringing bells as to what this is going to be. Does not look like it's involving the frontal lobes as much, a little bit. And we do see one small focus on the diffusion-weighted imaging of restricted diffusion in the subcortical aspects of the sort of parieto-occipital region on the left. And that did, in fact, show hypointensity on the ADC map. Now, why am I showing you an MRV? This happens to be a non-contrast time-of-flight MRV, which is how we do these in pregnant patients. Well, the reason I'm showing you the MRV is one possibility in a pregnant patient, and one thing that the emergency room is often trying to exclude is the possibility of durovenous sinus thrombosis, right? Because pregnancy is a hypercoagulable state. And I'm showing you this because the superior sagittal sinus, which would be the sinus that would be occluded if this were all secondary to venous ischemia, is normal, right? It's widely patent. And so we're not thinking this is going to be venous ischemia. So what this turns out to be is press, right? So tell me, here's a question for you. Wake up, stretch your arms and legs for a second. Do you only see press in the setting of hypertension? It's a bit of a leading question, right? The other reason I put in these questions is so that I have a chance to have a drink of coffee. It's 7 o'clock here, 7:30 now. All right, let's see what our respondent said. Every time I grab the mouse, I screw up the presentation, but that's okay. 50-50, huh? So in fact, the answer is no. You can see press in a lot of entities, and certainly hypertension is the most common. And this patient happened to have eclampsia, which at the end of the day is, one of the features is uncontrolled hypertension. Typically, the blood pressures in the setting of press are going to be, if it's from blood pressure elevations, to be really high. Systolics in the 200s typically, and diastolics, well over 100. But we can see it in a lot of other entities. So there are certain medications, oftentimes like liver meds from transplant meds like cyclosporin. You can see it in the setting of hemolytic uremia. You can see it in the setting of lupus, cryoglobulinemia. There are a lot of other entities. So yes, it is most commonly associated with uncontrolled hypertension. And the first thing I do when I come across a case that I think is going to be press is I open the chart and see what's their blood pressure. But if they don't have that, then you have to look a little bit deeper. And sometimes this will be the presenting symptom of what is causing their press, as some other underlying metabolic abnormality. All right, we can't avoid the leukodystrophies any longer. So here's a kid, 4-year-old, and they are having developmental regression. And I'm giving you just 2 T1 images, but because that's where the finding for this entity is best seen. And what we see is, so remember, you should sort of know what the typical progression of myelination patterns are for children. So the way I remember it is that on a T1 weighted image, the myelination pattern should be adult type, meaning that the white matter is brighter than the gray matter by age of 1. And on a T2 weighted image, conveniently, it should be adult type by the age of 2. So this patient is 4. So they should certainly have an adult type pattern. So we can't just say that what we're seeing here are areas of incomplete myelination. What we're in fact seeing is abnormal T1 hypointensity really diffusely throughout both anterior and posterior deep white matter. And you will notice, if you look closely, particularly on the image to the left, that there are actually some like striations, stripes in that deeper white matter. And that pattern has been specifically associated with this entity. So anybody be thinking about what leukodystrophy do you think this is going to be? It turns out this is metachromatic leukodystrophy. And this is in fact the most common dysmyelinating disease that we see in pediatric patients, still uncommon. Right, it's due to this the inherited deficiency of autosomal of aryl sulfatase A. They have symmetric involvement of both anterior and posterior parts of their brain, and this again, what's called tigroid striation. This is the second time tigers appear in this talk. Has been associated with this entity. Usually, it will not enhance. Occasionally, you might see just a touch of enhancement at the periphery of these areas of demyelination. And this is going to be in younger kids, right? So we typically think of this entity as occurring in early childhood under the age of 5. And that is going to be helpful when you're trying to differentiate it from the next entity we're going to talk about, which is this patient. So this is a 12-year-old, right? So a little bit older. And we have a T2, a T1 post-contrast, and a sagittal T1. And on this imaging, we see that the white matter abnormality is very much limited to the posterior brain. So we have ex vacuo enlargement of the atria. We have symmetric T2 hyperintensity at the margins of the atria. On that sagittal T1, which I think is a really interesting image, we see that the posterior aspect of the corpus callosum, specifically the splenium, is normally formed, right? So it was there if you look at the shape of that structure, but it has lost all of its myelin. So we just have this very discrete area of myelin loss in the splenium. On the post-contrast imaging in this patient, we see no enhancement. If this patient had active disease, again, you might see a hint of enhancement at this sort of advancing edge of this dysmyelinating process. So this is the other dysmyelinating disease that I think is worth knowing, and this is adrenoleukodystrophy. So this one is X-linked, autosomal recessive. So this was a very unusual patient in that it was female. It's typically male patients. And this tends to have that posterior predominant pattern. It's going to be in older kids typically. So I think if you are trying to differentiate these two and figure out ways to remember them, remember that metachromatic tends to be in younger patients. Adrenoleukodystrophy tends to be in slightly older patients. In fact, there are actually some adult variants of adrenoleukodystrophy where this may come on much later in life and have a much more insidious and slow course. Those are exceedingly rare. I have never seen one in clinical practice, but they are in the literature. And this is the entity that actually is treated. There are some fairly successful treatments for this, including Lorenzo's oil. There was a movie made about that some years ago. This patient actually happened to be on that treatment. And this disease, for her at least, had been stable for a couple of years without any evidence of progression at the time. So that's great, right? Usually these dysmyelinating diseases are very poor prognosis. They tend to end badly. So the fact that we do have a therapy that is at least to some extent successful in this entity is good news, right? Okay, let's talk about another dysmyelinating disorder. So here we have a much younger patient. This patient is only 7 months old. So you could say, well, I'm only getting T2 images. We know that myelination is not going to be the adult type on a T2 weighted image, but this is still abnormal, right? So you should see some degree of myelination, particularly in tracts like the corticospinal tracts, some of the deep structures, thalami, by the age of 7 months. Here we have extensive, symmetric, and diffuse T2 hyperintensity throughout all of the white matter. And so I think this is a case where you would definitely have to give a differential if you didn't have more information. But I'm going to give you more information because this is another entity that is exceedingly rare, but likes to show up on exams, especially exams that are specific to neuroradiology because of this. Right? So this patient got spectroscopy, and on their spectroscopy, you can see that they have that third peak is significantly elevated over the other two. So remember that the order in which the peaks go, the main three metabolites that we're often looking at are actually alphabetical. And so even though it's very simplistic, I'm a simple guy. That's how I remember which ones they are. So choline is going to be first, creatine, because CH comes before CR, and then NAA is going to be that last peak. And it's the NAA peak in this case that is markedly elevated. And sometimes it's so elevated in this entity that the other ones almost don't show up. It outstrips the baseline by so far. And so this is going to be Canavan disease. Again, this is going to be really early onset, right? So these typically in the first few months of life. And the reason that they have that markedly elevated NAA peak is because they lack the N-acetyl aspartate enzyme to break it down. And so they just continue to accumulate NAA in their brain. And so you get this huge peak. They tend to have macrocephaly. They will often have involvement of subcortical and deep structures. I love this quote. This quote actually comes directly from Dr. Ann Osborne's textbook in neuroradiology. And as everybody I think knows, she is sort of the preeminent neuroradiologist in the world. I am not a fan of spectroscopy. And so her statement of this is one of the few diseases to which spectroscopy has made a contribution, I find very amusing. I tend to avoid spectroscopy whenever I can because I find it to be incredibly nonspecific. And as Dr. Osborne references, this may be one of the only diseases where the spectra actually can help you come to a specific diagnosis. All right. Let's move on to another young patient, although not quite as young. This is a 34-year-old. Here's a case with the arrow sign, which I'm sure people appreciate. So the non-contrast head CT here, we see extensive intraventricular hemorrhage in the lateral and third ventricles, fairly non-specific, right? There may be a little bit of hydrocephalus developing. You can see a little bit of hypodensity in the deep white matter adjacent to that frontal horn in the right lateral ventricle. But now I've given you the facial bone CT, or a piece of the face anyway, and we see that the arrow is pointing out a large nasal septal defect. Unfortunately, this is something that we see not infrequently in the US, and that is cocaine, although it could have been other drugs. So remember that cocaine, just like methamphetamines and other drugs, is a strong vasoconstrictor. And so what you're going to see when you have a patient who has taken a dose of one of these very active vasoconstrictive substances is essentially the pattern you might expect in the setting of hypertension, because really that's what it's from. It's a vasoconstrictor, and you're causing all of these vessels to really spasm. And this patient has a basal ganglia hemorrhage, which has extended into the ventricular system, just like you might expect to see basal ganglia hemorrhages in patients with uncontrolled hypertension. The nasal septal perforation is from the same effect, right? So your nasal septum, you get this massive vasoconstriction from inhaling cocaine through the nose, and as a result, you get necrosis of the nasal septum. So it's the same pattern. This could have been any other strong vasoconstrictor, but in a young patient, when I see a hypertensive hemorrhage, maybe they're just unfortunate and have uncontrolled hypertension, but I always, at least when I'm speaking to the clinician, say you really should do a drug screen, because a patient this age shouldn't have hypertensive hemorrhages, hopefully. All right, let's move on to a little bit more of a zebra. So this is I have to give you the history for this patient. So this is a patient who also happened to have a drug overdose, but they recovered. And in fact, at the time they had their drug overdose, their MRI was normal. They didn't have any infarct. They didn't have anything. They didn't have any hemorrhage. So they went to a rehab facility, and about a month into their rehab, they suddenly had a precipitous decline in their status. They became unresponsive over the course of a day or two, were brought back to the hospital, and they got an MRI. And now they have extensive signal abnormality, right? And this is all new. So when they got their scan, I promise you, a month ago, it was normal. Now on the flare, you can see they have confluent, extensive T2 hyperintensity throughout the entirety of the white matter. And on the diffusion-weighted imaging, at first glance, you would assume that this must be T2 shine through. But in fact, when you look at the ADC map, you can see that all of this hyperintensity is quite dark on ADC. And so this is truly restricted diffusion involving the entirety of the white matter. And so you would think that, boy, that is not a pattern compatible with a particularly good outcome. And if you're thinking that, then you are correct. This is an entity called delayed post-hypoxic leukoencephalopathy. It is not well understood, but it tends to follow global injuries, often drug overdoses, but not always. It can occasionally be seen. It's been reported in carbon monoxide exposure. It's been reported in other causes of hypoxia. And they has this very classic pattern of the patient will be fine for about a month, sometimes a little longer, and then they have this precipitous decline, and they undergo this essentially diffuse demyelination of the entirety of their white matter. The outcomes are very poor. It is not universally fatal, but patients are almost entirely left with a high degree of morbidity in this setting, as you might imagine. So something to think about, not common, but you really have to look into the history if you want to consider making this diagnosis. All right, how are we doing for time? Good. Wanted to leave a little bit of time for questions. So this, I think, is our last case. This is a recent case that we had at OHSU, which I think was one of the more beautiful examples of this entity. So again, a somewhat older patient, 62-year-old, altered mental status, came into the ER, got an MRI. On the far left, we have our 3D FLAIR images, and on the last three images are post-contrast 3D T1 weighted imaging. This is a subtle diagnosis to make until you see it, and when you see it, it jumps out at you. But again, the hardest things to see in radiology are either the things that are not there, right? So things that are absent, or things that are symmetric and bilateral. And in this case, we have a symmetric bilateral process. So on the first FLAIR image, there is subtle T2 hyperintensity in the medial thalami bilaterally. On the next image, the FLAIR image, you see it's hard on this image, I grant you, but when you look at the posts, you can agree that it's real. The mammillary bodies look abnormal. On the post-contrast imaging in images 1 and 3, you can see that, in fact, the mammillary bodies are avidly enhancing symmetrically. And there are very few things that cause mammillary body enhancement or signal abnormality in a symmetric pattern like this. So you should be very much limiting your differential diagnosis at this point. And we also see that second post-contrast image, we see that the medial thalami have these little slivers of enhancement, which again are very symmetric adjacent to the third ventricle. And so if you see involvement of thalami, mammillary bodies, you should be thinking that this could be Wernicke encephalopathy. And in fact, that's what this is. So this is caused by vitamin B1 deficiency or thiamine deficiency, very commonly seen in patients with poor nutritional intake. So in books and exams, they will often say alcoholics. It doesn't have to be alcoholics. If you I remember a patient, shouldn't laugh, it's not funny. We had a patient some years ago who was an elderly man who basically subsisted on chips, and he ended up with Wernicke's encephalopathy. If you have a terrible diet, you can get this the same way. So you really, this is why you have to have a sort of balanced diet. Periaqueductal gray mammillary bodies, think midline structures, are the ones that are going to be involved in these patients. In the acute setting, as was in this case, you may see enhancement, you may see diffusion restriction, in fact. This patient, there was not diffusion restriction in those structures, so I didn't show you those images. And they're going to present with vision changes, gait instability, confusion, etc. The therapy obviously is you give them thiamine, right? And some of this may be reversible if it's been going on for long enough. They may have permanent deficits, but thiamine is the treatment of choice. So I wanted to leave a few minutes at the end for questions. This is my email address. That's my, whatever we're supposed to call it now, Twitter or X or whatever foolish thing it's been changed to. And I would love to hear questions from you or thoughts from you. But that being said, it's been a pleasure to speak with you this morning. And I hope you saw some things that maybe you hadn't seen before. So I think I'll turn it over to Dr. Adiki.
Thank you very much, Dr. Nickerson, for this wonderful lecture. It's really well outlined and it's quite educating. So I don't know, thank you so much. I believe everyone here that attended, they're so happy to have listened to you, and I'm sure we've all learned one or two things that we're going with. Thanks so much for your time once again. So for the question and answer, please, if you have a question, kindly drop them in the Q&A chat box. So get down to it immediately.
I'm seeing answers to some of my questions in the chat. It looks like people were all over it, didn't hear us. So lots of Mark Yafama, excellent, exactly. Paramagnetic, excellent, very, very good. Yeah, and you're welcome to chat a question too. Yeah.
Okay, so please, if you have a question, please just drop a question, anyone. Okay. Okay, they are really grateful for the wonderful lecture, and a lot of people are saying that on the chat box. So we are really grateful.
Great. Well, I won't keep people beyond if they need to go to work or get back to work.
Okay. So I think there's a question now. Let's see.
Oh, the tiger eye sign. Yeah. The tiger eye sign is, I don't know who made that up. I've seen better examples of it, but it doesn't look like a tiger eye to me.
Okay, so I think that's that for the webinar for today. Thank you so much, Dr. Nickerson, for this wonderful lecture. And I believe that you will oblige us when next we call you. I know you're very busy, so but please, I really wish we call you next time. I really believe that you will oblige us your presence.
Thank you. It's been a pleasure to speak to all of you this morning. I hope you all have a great rest of your day.
Thank you very much. Thank you very much. Do have a wonderful day.